50 years, 70 years के आसपास, 70 years था, and fever था उसको 2 weeks से, और basic report हमने कर ली, but कुछ निकला नहीं, तो it came out to very interesting findings. So we have Dr. Alina with us. Dr. Alina is study resident. She has given her practice examination, is waiting for results. ठीक है, बोल रही हो। अच्छा, तो Dr. Anita joined. So now we are live on YouTube and Zoom. ये सब join किया? So I request Dr. Alina to present the case and we'll have some discussion. To chair the session, we have Dr. Ruby Bansal. We all know she is HIV and infectious specialist, and Dr. Anivita will be joining from Zoom link. So she will be joining, and we'll have some discussion. But we have a delay of almost 15 minutes because of some technical glitch, and if Dr. Bansal allows that, we can have 15 minutes. Right. So we have some fast, okay?
Good afternoon, all. Myself, Dr. Alina Ivan Theodore. I am ANP JR3 from Max Vaishali Hospital. So today I am presenting an interesting case of fever with pancytopenia. The patient Rakesh Kumar Goyalji, 73-year-old male. Date of admission was 25th July 2025 and date of discharge was August 13, 2025. He was a resident of Meerut. Chief presenting complaints of the patient were fever from past 14 days, generalized weakness from past 10 to 12 days, cough from past 10 to 12 days. History of presenting illness: patient was apparently normal 2 weeks back, then he complained of fever which was high grade in nature associated with chills. Patient also had severe generalized weakness from past 10 to 12 days. Patient also had cough with minimal amount of sputum from past 10 to 12 days. Cough is not associated with any shortness of breath, no history of any diurnal or postural variation, no history of evening rise of temperature or weight loss. The patient visited internal medicine OPD for all these complaints. Patient was evaluated and managed symptomatically on OPD basis, but patient had persistent fever and routine evaluations relieved pancytopenia. So the patient was admitted and was started on with initial symptomatic treatment. Further evaluation was done on IPD basis. Past history. There's a significant past history. The patient was previously admitted for systemic histoplasmosis and was treated for the same and was on itraconazole for past 6 months. He's also a non-case of hypertension. No relevant family history, personal history, normal bowel bladder habits, not an alcoholic. He's a reformed smoker. Drug history on antihypertensives and inhalers on and off. Allergy history, no past history of any allergy to any medications. So on general examination, patient was conscious and cooperative. There was pallor, no icterus, cyanosis, clubbing, and lymphadenopathy on general examination and edema. Vitals were BP 110 by 70 mmHg in right arm supine position. Heart rate was 121 per minute. Regular in rate, rhythm, character, no radial radiofemoral delay. All peripheral pulses were palpable. Normal vessel wall thickness. SpO2 was 98% at room air on admission. But the patient was febrile. He had a temperature of 101 degree Fahrenheit. Respiratory rate was 14 per minute abdominothoracic. So on system examination, the relevant findings were respiratory system. There was bilateral entry, but air entry. Bilateral crackles were there, and bilateral expiratory wheeze was also present. Serious S1, S2 heard. CNS patient was conscious, oriented to time, place, person. There was no any other focal neurological deficits. Per abdomen findings, the abdomen was soft, non-tender, and no other findings. So the patient was admitted. Then the course in hospital, patient was admitted and was started on with initial symptomatic treatment with IV antibiotics, IV fluids, and rest symptomatic treatment. Clinical, laboratory, and radiological evaluation of the patient was done. Initial investigations were done, which revealed pancytopenia. Serum ferritin levels were high, 2,557. The low albumin levels and elevated inflammatory markers like D-dimer and procalcitonin. Patient was initially maintaining saturation on room air, but gradually required oxygen support via face mask. In view of past history of systemic histoplasmosis and current clinical and lab findings, Patient was planned for bone marrow aspiration and biopsy, along with other tests of histoplasmosis like urine histoplasma antigen rapid test, which came out to be negative. Bone marrow biopsy revealed trilineage hematopoiesis with numerous parts of GMS positive yeast forms morphologically compatible with histoplasma and was negative for any malignancy. Hematology reference was done. Patient underwent PET CT, which showed bilateral hilar and mediastinal lymphadenopathy with hepatosplenomegaly, bone marrow hypermetabolism, bilateral pleural effusion, and chronic age-related cerebral atrophy. The patient also was evaluated for any kind of immunodeficiency because it was a second admission. HIV was negative and CD4 counts were low, that is 133.64. Patient also underwent an FNEC of supraclavicular node as per the PET CT finding, and the FNH, this report was suggestive of fungal lymphadenitis, likely histoplasmosis. So the patient was started on with liposomal amphotericin B in a dose of 3 to 5 mg per kg per day and was continued for a total of 2 weeks. Patient was also started on with itraconazole before stopping amphotericin B and was continued. Patient was shifted in between, the patient condition deteriorated and patient was shifted to ICU in view of increased respiratory distress and started on with injectable steroids in view of bronchospasm and was monitored closely in ICU. Gradually, patient started to respond IV amphotericin B, and it was continued for a total of 2 weeks and was overlapped with itraconazole, and steroids were tapered off once the patient was better. The rest symptomatic treatment was continued. As a part of the evaluation, patient NK cell, B cell, and T cell subset analysis was done along with whole genome exome sequencing, which came out to be normal. During the stay, multi-speciality opinions were taken and advice was followed. Patient blood counts gradually became normal. Patient was finally discharged on oral itraconazole and other supportive treatment. So this was the relevant laboratory investigation. This was the trend of hemoglobin of the patient. Initially, it was around less than 10, 9.8. And then gradually, the patient had a dip in hemoglobin. And finally, when the patient started to respond to amphotericin B, the patient count started to increase. This was a TLC trend, and this was a platelet trend. The CBC improved gradually. Other relevant laboratory findings of ferritin levels were 2557. Urine routine microscopy was normal. The urine for histoplasma rapid test was negative, and the immunoglobulin levels were done. It was normal, and CD4 count was low, 133.64. Other HIV tests were negative. Ultrasound was done. Hepatosplenomegaly was there with GB edema, and PET CT was also done, which I've already discussed previously. And the bone marrow examination was suggestive of histoplasma, like organisms. This was the patient's bone marrow biopsy slide. This is actually a slide which I have taken from the internet, which shows histoplasma. So this is the patient slide, and this is the slide which I have taken from internet. So this was the patient's X-ray when he got admitted, and in between when the patient condition worsened, this was the X-ray. So diagnosis was relapse of systemic histoplasmosis with isolated CD4 lymphocytopenia. So the diagnostic and therapeutic dilemmas were isolated CD4 lymphocytopenia requiring genetic and immunological workup, management of disseminated fungal infection in the elderly immunodeficient host, choice, dosing, and monitoring for long-term antifungal secondary prophylaxis. Discussion.
We are seeing such patient in immunocompetent patients. As such, like if only the HIV is negative, that does not mean he is immunocompetent. So otherwise, age related with the age in previous history and might not be properly treated previously, or it is a infection, or like it is a infection which was there and which reoccurred. So these are the now cases. We are just getting. I think every time once or twice we are getting this histoplasmosis and nocardiosis or such infections which are mainly prone to the HIV positive host, but now we are getting the HIV negative. Only the difference is we are not doing the CD4 count in the like immunocompetent host, except the HIV patients. But I feel if we are doing the CD4 count, even in the tuberculosis, we will find that it is low. Even in any other infection, we can just get it over. But these are not relevant. We are not getting any benefit out of the CD count because it's not going to improve with such other things. So these are the infections which are well established and they are coming.
Nimita has also joined. Nimita, your comments upon this case of recurrent histoplasmosis?
Lovely case, ma'am. So, as Dr. Ruby ma'am has summarized, histoplasmosis is not just defined to HIV positive population. We are seeing a lot of cases and coming from all parts of the country, not just the North Indian Gangetic belt like it used to be previously defined as. We have recently, in fact, published a case series of 15 cases of histoplasmosis which were non-HIV positive. In the last 2 years, we saw quite a lot of disseminated histoplasmosis. The key feature here that has been noted is the CD4 count being low.
Just
So
speak
there
louder,
are...
bit louder.
Hello, can you hear me?
Yeah, it's on Zoom.
Yeah.
She can-
So
Yes,
my
yes.
the unique part on this case which was very interesting was the CD4 count being low and the patient being labeled as idiopathic CD4 lymphocytopenia. But what can happen with histoplasmosis is the bone marrow suppression, which can also mimic pancytopenia, which can lead to interim reduction in CD4 count, which might not be the baseline status. So it will be interesting to see that how the CD4 count fares on treatment and what is the baseline CD4 count of the patient before and after the treatment. Only then we'll be able to categorically determine that this is CD4 lymphocytopenia. This could very much be a risk factor, but exposure, environmental exposure, simple diabetes.
So patient is having patient is a chronic smoker and known cause COPD, and he had histoplasmosis in the past. So I think this would be the risk factors for getting recurrent histoplasmosis in this patient.
That could be the case, sir. Also, sir, was the previous treatment completed? So histoplasma itself has a very high chance of recurrence if the treatment has been partially received. So that
Right.
could also be there. It's definitely very interesting. There are only possibilities and theories, but practically he will have to be treated like the first case all over again. So very interesting case, sir.
So how you recommend the course of treatment, overall the duration of treatment of these patients?
So duration of the treatment for pulmonary histoplasmosis, which we don't usually see, is short. But for disseminated histoplasmosis, which we usually see in our setting, is minimum a year of therapy. After
Minimum a year.
Minimum a year. After the immunosuppression has been reversed, if at all there's a immunosuppression. So 1 year of complete treatment, and at the end of the year, I would actually want to repeat a PET scan to see whether the uptake has reduced or not, whether the clinical and radiological signs have completely resolved or not, and then only I would want to stop the treatment. And meanwhile, therapeutic drug monitoring is very important because itraconazole ke PK/PD parameters are very variable. So even if you're giving a year of treatment, it might not be getting absorbed properly. So therapeutic drug monitoring for itraconazole levels and a year of treatment is something that we must aim for.
So as Dr. Anita said, rightly said that we have to give a treatment at least for a year, and because of this drug of varied absorption, we should actually take the drug testing also, the drug profile, as well as the repeat PET CT after a year to see the resolution. Because previously, all the patient had histoplasmosis, the patient not have treated completely, so it has recurred. And actually, for us, it was a very challenging case because patient was very sick, having very high grade fever, restlessness, and attendants are also questioning us that why the patient is fever not going on. So initially, we were not suspecting histoplasma because he's a immunocompetent patient. But when we did, the bone marrow and other tests, histoplasmosis, actually it is quite apparent, it's visible. And we actually went to the lab and just saw the histoplasmosis is actually disseminated histoplasmosis. So it's very difficult to treat, and you can see the patient deteriorated very fast. And we had to shift the patient to ICU desaturated, and of course the steroid was being given, and patient got better. So luckily the patient is doing well. He has almost 3 months, 3 months of itraconazole, and he's afebrile now. And following the OPD, I think last 2 weeks he came, and he's now better. Pancytopenia has resolved, and no fever at all. So it's very important to understand that histoplasmosis, as Dr. Ruby once said, is not very uncommon. and it is not very uncommon. It's not very uncommon. It should be there in only immunocompromised patient. We have seen, I think we have presented 1 or 2 cases before also, that it is there in immunocompromised patient as well. CD4, definitely it could be an isolated finding because we have done the genomic testing and it came out to negative. So there is no genetic factors in this patient. And CD4 count, as Dr. Ruby has rightly said, that in any infections, like tuberculosis or any infection, the CD4 count might go down. Suppose if we repeat CD4 count, I think we could get a normal report as well, right? So the follow the patient is very important. The drug assay we need to look on, and after a year, we have to repeat PET to see the residual disease activity. So I think it's a very interesting. Etoprolol dose is 100 mg twice daily. 200 mg twice daily, right? Initially, we give for 200 mg twice a daily for a week, and then we give 200 mg twice daily for at least a year, definitely. So what could be the side effects of this drug? We have monitored. So just a brief discussion, and then we can close the session.
Urine antigen was negative.
Urine antigen was negative.
Stayed in this patient and smoking.
So it's not actually, if you look into the, it's not a immunocompromised. Yeah, it's not a category, not immunocompromised. Patient is chronic smoker and COPD. So that's a risk factor of developing histoplasmosis. Okay. For immunocompromised, we would say that patient is HIV positive or very uncontrolled diabetes also. As such, there was not such a case. CD4 count, as CD4 lymphocyte were low actually. But it's not a matter that if there is low CD4, the patient is labeled as immunocompromised.
Not like we are not doing the CD4 in any other patient except the
Fasting. Normally, the disseminated or systemic histoplasmosis occurs in immunocompromised patient.
yes.
I'm asking what is the cause of immunocompromised state in this patient?
The patient was a reformed smoker.
HIV is like
It is HIV.
maybe old age
The age
itself.
itself is a
70
plus COPD,
COPD.
plus chronic
No
smoker.
diabetic.
patient is non-diabetic, sir.
Non-diabetic.
Patient non-diabetic.
Yeah.
So Anivita, do you have this? There's query that why the disseminated histoplasmosis in this patient.
Sorry, sir, could you repeat the question?
Patient is having disseminated histoplasmosis, and
Ji,
patient
sir.
is not having history of diabetes or HIV state and all. Still, patient presented with the
Absolutely.
disseminated histoplasmosis. So,
Absolutely, sir. So what we saw in our case study was also this, that we had 15 patients who were non-HIV positive who had disseminated histoplasmosis, amongst which there were 5-6 patients, if I remember correctly, who didn't have any demonstrable immunosuppression. So there were young kids with absolutely no comorbidities, no immunosuppression, who just went out for trekking and camping near the rivers or did river rafting, and they ended up getting histoplasmosis. So there are a lot of I think, sir, basically not every immunodeficiency is getting tested, and not every immunosuppression can be picked up on time, but environmental exposure is what leads to disseminated histoplasmosis. So I feel we can dig deeper if the patient is having recurrent episodes, because that definitely warrants a proper immunological profile to be done. But a single odd case, if we are sure that there is good environmental exposure, it can be explained, sir.
So I think one of the patient is just 34 years of age and is currently admitted with another unit. 34 years male, without any history of HIV or something, right? Is having recurrent disseminated histoplasmosis. So I think it is there actually. That's why I say it's not very uncommon, and we should actually suspect in an immunocompromised patient as well. So I think in this patient, I would say that it is immunocompromised. Though patient is age factor is around 70 years, chronic smoker and underlying COPD, that could be a risk factor for developing this histoplasmosis. So
plus, sir, a lot of flooding that we are seeing this year in a lot of parts of the country, that adds to disseminated histoplasmosis exposures. So recent times we are seeing a lot of we are seeing a lot of other waterborne and soil-borne infections, and high surge on cryptococcus also because of flooding and waterlogging. So this environmental exposures are very important in histo.
Discussion: histoplasmosis is a systemic mycosis caused by a dimorphic fungus, Histoplasma capsulatum, endemic in certain geographic regions Infection is acquired by inhalation of microconidia from contaminated soil, especially bird or bat droppings. While most infections are self-limited or asymptomatic, systemic histoplasmosis can occur, particularly in immunocompromised individuals, and has significant morbidity and mortality. Types of histoplasmosis. Histoplasmosis can be asymptomatic, most common, found incidentally. It can be there as a lung involvement, acute pulmonary, chronic pulmonary resembles tuberculosis, or it can present with cavitations. It can be disseminated, as in our case, systemic, life-threatening with multi-organ involvement. So, systemic or disseminated histoplasmosis occur when histoplasma disseminates via hematogenous or lymphatic spread, especially in those with compromised cellular immunity. Risk groups can be HIV patients, organ transplant recipients, patients on TNF-alpha inhibitors or long-term corticosteroids. In case of hematological malignancies, infants and elderly. So, recurrence of systemic histoplasmosis. Recurrence is the reappearance of systemic disease after an initial clinical response, either due to relapse or reinfection. Causes of recurrence are inadequate initial treatment, HIV, persistent immunosuppression, immunodeficiency, poor adherence to therapy, latent infection reactivation, lack of secondary prophylaxis, drug interaction, or malabsorption of drug. Diagnostic evaluation, all of these are the diagnostic evaluation: histoplasma antigen detection, urine and serum, fungal cultures, bone marrow, blood or tissue biopsy, histopathology, yeast inside the macrophages, serological tests like complement fixation, molecular tests, bone marrow biopsy. Treatment of recurrence of systemic histoplasmosis. In severe case, IV liposomal amphotericin B in a dose of 3 to 5 mg per kg should be given for 2 weeks at least, and can extend up to 6 weeks in case of CNS involvement. In mild case, we can even give itraconazole 200 mg thrice daily for 3 days, then twice daily, minimum of 12 months. So before stopping liposomal amphotericin B, we have to start itraconazole in a dose of 200 mg thrice daily for 3 days, and then we can stop liposomal amphotericin B after 2 weeks, and then you can continue itraconazole. Step down or maintenance therapy. Itraconazole 200 mg BD continued for at least of 12 months or until antigen level becomes undetectable, or in case of HIV patients, if CD4 is more than 150 for more than or equal to 6 months with ART, and the patient is having no clinical symptoms. Parameters that should be monitored when the patient is on medication: clinical review monthly initially, urine or serum histoplasma antigen monthly or 6 monthly, then 3 monthly. Itraconazole drug levels should be monitored at 2 weeks, then periodically. Liver and renal function monthly during the therapy. If the patient is HIV positive, then CD4 counts. Summary: this is a case of isolated CD4 lymphocytopenia presenting with recurrent systemic histoplasmosis in an immunocompetent HIV negative 73-year-old male. Unlike typical histoplasmosis seen in profoundly immunosuppressed individuals, such recurrence in the setting of isolated CD4 deficiency is uncommon, with only a few similar cases reported in the literature. Early diagnosis through bone marrow biopsy and prompt antifungal therapy led to the clinical recovery, highlighting the importance of considering underlying immune dysregulation even in the absence of classic risk factors. So this is one of the similar disseminated histoplasmosis which was reported as a case report in immunocompetent patient in Western India, a case from Rajasthan. Thank you.
Thank you, Lina. And Dr. Vatsa, your closing comments on this particular case.
I think it was a wonderful case and very well presented by Dr. Alina. So the take-home message is that like we should think of all atypical infection, not only in immunocompromised but immunocompetent host cell. And the other way around, every person with such infection should be tested for HIV also. So there are, two way around the things. So we should not miss anything in such things.
So Nimita, your comments, like your closing comments.
Sorry, sir, my net is a little off. Can you
Okay,
repeat
no,
that?
Shubha, you can speak a little loud.
Hello?
Yes, we are. You're audible.
Sid, I was my connection was getting cut. I couldn't hear the previous segment. Uh, hello.
Yes.
Hanji, sir, can you repeat the question again? Sorry, voice
Sir,
was
what is your
cutting.
take-home message to all the delegates today?
Oh, lovely. So I think, sir, histoplasmosis was used to be considered like a rare infection and only for HIV positive, and it's not the case anymore. So any patient who's coming as a PUO, when we are having lymphadenopathy, when we are having hepatosplenomegaly, and when we are having some amount of bone marrow suppression, we should definitely suspect histoplasmosis. And the only way to diagnose is a bone marrow biopsy, which we anyways do as a part of PUO workup. The other thing that should help us clinch the diagnosis or suspect histo very highly is when we get adrenal uptakes. So more than often patients end up having bilateral adrenal mass, and then they go to an endocrinologist or to a urologist, and on the biopsy more than often histoplasmosis is recovered. So we have a case series of adrenal masses in which there are 30% cases of histo, 20, and rest of the 70 are TB, and none of them were actually adrenal adenomas. So this just points towards a shifting epidemiology and better diagnostics. We are thankfully all very privileged that we are in Delhi where the diagnostics are very good. So the histoplasma pickup rates are very good on biopsies and fungal cultures. However, the urinary histoplasma antigen is a little iffy. So as in this case, the urinary histoplasma antigen also came out to be negative. Yet the bone marrow showed that the culture has histoplasmosis. So we have to take the urinary histoplasma antigen with a pinch of salt because it's recently it is showing a lot of poor sensitivity specificity despite of what the literature says. So our clinical suspicion, a PET or a bone marrow biopsy helps us clinch the diagnosis of histo, and HIV with diabetes and any other immunocompromised status, definitely our differential goes one up. So whenever suspecting TB, also keep in the back of the head कि histo bhi ho sakta hai, is how I feel should be the case.
Right. Thank you, Nimita. And it answers Viresh's question that urinary antigen was negative. It has a poor specificity and sensitivity. So if you want to diagnose, it is bone marrow and the PET, and you have to localize. And if there is a lymph node, definitely fungal culture and fungal biopsy would help. Right. So thank you, Arina, for a wonderful case. And I request Dr. Vikram Tavas to present the memento to Dr. Arina. निमिता आपका प्लांटर हम पूरे कर देंगे आपको ठीक है Thank you, Nimita, for joining, and we will start in the second case. Stay around because this is another case of fever. And to chair the session, I invite Dr. Vikram. Please come just in front. And Dr. Vibhu Mittal, our colleague and gastroenterologist at Max Patpagans. And this case will be moderated by Dr. Bansal. And I request Bansal to introduce the speaker.
Greeting, good afternoon, everyone. As Dr. Pankaj has already mentioned, that fever is still one of the most difficult thing to handle, and especially in present day practice, internists are left mainly with fever and some other very less cases. So this is an interesting case of fever which relates with rash, and then a lot of things are reported. And within this case, we have first year DSPJR, Dr. Aditya Jain, will be presenting this case. So I hand over to Dr. Aditya for the presentation.
Thank you, sir. So good afternoon, everyone. So I am Dr. Aditya Jain, DNB first year resident at Max Hospital, Patpur, and I'm going to present an interesting case of fever with rash. So a 62-year-old male who is a government employee, desk job by occupation, a resident of Delhi and Hindu by religion, came with chief complaints of fever since 6 days, rash on both feet since 2 days, and nausea and loss of appetite since 2 days. So history of presenting illness. The patient was apparently well. Patient was apparently well 6 days back when he developed a fever, which was sudden in onset, was up to 102 degree Fahrenheit, with no diurnal variations, was associated with chills but no rigors, and was relieved with medications for a few hours. It was associated with generalized body ache, malaise, and fatigue. The body ache was diffuse, involving limbs, back, and joints, with no focal swelling, redness, or restriction of movement. The patient also complained of nausea for the past 2 days with a mild epigastric discomfort. It was aggravated with food intake and was relieved with antiemetics. It was associated with loss of appetite. The patient also had a reddish rash over the dorsal aspect of bilateral feet. The rash was erythematous, maculopapular, and non-pruritic, associated with blistering or mucosal involvement. It appeared following the intake of NSAIDs for body ache, with symptoms developing after 12 to 14 hours of drug exposure. There is no history of similar reaction in the past to NSAIDs or any other medications. So there was no history of cough, sputum, breathlessness, sore throat or chest pain, no history of dysuria, frequency, urgency or hematuria, no history of headache or neck stiffness, no history of abdominal pain, constipation or diarrhea, no history of ear pain, discharge or sinus tenderness. So past history, the patient is a known diabetic for since last 4 years. He is on tablet sitagliptin 100 mg, metformin 500 mg, and dapagliflozin 10 mg once daily with well-controlled blood sugars. There is no past history of atopy, no history of contact with TB patients. There is no similar illness in the family. Personal history, he is a vegetarian by diet with reduced appetite, normal bowel and bladder habits, normal sleep, and no habits. So on examination, a 62-year-old obese male patient was well built and nourished, was conscious, anxious, alert, and well oriented to time, place, and person.
Just positive.
Vitals were all stable. There was a mild tachycardia, 104 beats per minute. BP was normal, respiratory rate was normal, saturation was normal at room air. There is no pallor icterus, clubbing cyanosis, lymphadenopathy, or edema. Erythematous maculopapular rash was present on dorsum of both feet of approximately 2 by 3 centimeter of size. There was no relevant finding on the systemic examination. However, a mild epigastric tenderness was present on per abdominal examination. So the course of the patient appeared systemically unwell but has no obvious source of infection on initial evaluation. Basic investigation for the differential of fever were sent. Cultures were sent before initiating antibiotics, and patient was started empirically on injection ceftriaxone 2 grams twice daily. On initial evaluation, there was the hemoglobin, total leukocyte count, differential count, and platelets were all normal. However, the platelets were on a higher side. The CRP was elevated up to 162 milligrams per liter. Procalcitonin was normal. Typhoid malarial antigen, peripheral smear for malaria, dengue, and S1 IgM were negative. Urine RM shows 1 plus glucose with no other abnormality, and ultrasound and chest X-ray of the patient were within normal limits. So clinical evolution. The patient was initially managed conservatively with a provisional diagnosis of enteric fever with queried drug rash. The fever and rash of the patient started to improve with 4 to 5 days of empirical antibiotics, and the blood and urine culture came out to be sterile. So now the patient developed abdominal discomfort with 1 to 2 episodes of semi-solid stools per day.
At this point of time, you were planning to discharge the patient. The patient was including fever subsided, the pain subsided, but meanwhile the patient developed. Yeah, please.
The stools were semi-solid in consistency, not mixed with blood and mucus, not associated with tenesmus, urgency, or foul smell. They were associated with the crampy lower abdominal pain. There was no history of similar complaints in the past. Patient also developed pain in the front of knee, just below the patella. The pain was dull, of insidious onset, aggravated by activity and relieved by NSAIDs and rest. The patient also complained of localized tenderness at the patellar tendon insertion. His TLC and platelets also started to rise, and CRP was persistently raised. So this is the trend of the TLC and platelet count. The TLC was initially 6,000 and it rose up to 25,000 in around 10 to 12 days. The platelet count also rise from 4 lakhs to 10 lakhs in the same time period. The differential count was neutrophilic. There was 90% neutrophils in the differential count, and the CRP was persistently elevated.
So at this point, we thought we are dealing with some septicemia, which we are not able to, pinpoint.
So in view of persistent fever, neutrophilic rise of TLC, persistently raised CRP, and new onset symptoms, CCT, thorax, and whole abdomen was done, and repeat cultures were sent. So this is the report of CT whole abdomen with the test. It only shows circumferential mural thickening in the bowel loops with surrounding stickiness and ascites suggestive of acute inflammatory or infective process. So the repeat investigations and culture showed the stool investigation was all normal, including there was no ova, cyst, trophocytes, or pus in the stools. The repeat blood culture was normal. Urine culture, stool cultures was normal. Clostridium difficile toxin in the stools was negative. However, the fecal calprotectin was elevated up to 641 micrograms per gram, which is a marker of intestinal inflammation. Peripheral smear show leukocytosis with neutrophilia with thrombocytosis. A hematology consult was taken for the elevated platelet counts. So they suggested a myeloproliferative neoplasia panel, which came out to be negative. They also suggested for a biopsy if no other cause of the fever and this rise in platelet was not found. But the patient denied for a bone marrow biopsy. ANA by immunofluorescence was done, which came out to be positive. It was 1/320 positive and a speckled pattern and 2+ on immunofluorescence. ANA line immunoassay and a ENA panel was done, which shows AMA-M2 positive antibodies. It is specific for primary biliary cirrhosis, but however, it could be positive in 2 to 4% of normal individual. As the patient was not having any symptoms related to liver, and the CT of the whole abdomen showed nothing significant finding in the liver, this was considered to be as a normal finding in this individual. The HLA-B27 was also negative in the patient, and hepatitis B and C serology and HIV was also negative. So in view of neutrophilic rise of TLC and above mentioned intestinal findings in the CT whole abdomen, and considering the persistent state of inflammation, his antibiotics were upgraded to injection meropenem 1 gram thrice daily for a broad spectrum gram-negative and anaerobe cover. The cultures were sterile and there was no improvement after 3 to 4 days of empirical antibiotics. The CRP remained persistently elevated and the TLC and platelet count continues to rise. So I would like to ask, what do you think at this point?
So we have to, you can take opinion. Because not guideline the diagnosis. What do you think in this position?
Only positive finding which we could find out in that case in them was the circumferential thickening in the intestine. And other than that, it was not pointing towards any other focal anomaly was found. So we next will with this thing of exploring the intestine.
I think we do a lot of see cases with enteric-like illnesses and there's no abdominal thickening. But the point against this because high count and high CRP procure. So possibly because of sepsis. Yeah.
Very high platelet.
Right. And because in any sepsis, I've seen a lot of high platelets in the liver absence of food. One patient admitted with us, the platelet was 9 lakhs and patient is recovering.
In this case, the platelet went up to 12 lakhs.
Yeah. So I think in any infections, I think platelets naturally comes as cirrhosis there. So it wouldn't have, it should have the underlying infection that is causing this high platelet count. Because your opinion.
I was involved in the case, so I know what finally happened. But yes, I only talk about this. Yeah, my impression at this time was we might be dealing with infection only because the history was not so disappointing. Yes, infection is likely to be GI origin because we have a circumferential technique. And then it becomes just like with rising TLC. Yeah. Platelets can happen with any inflammation, infection, but high TLC is unlikely to be associated with enteric. Rheumatologists were involved to rule out other things. So atypical infection coverage was recommended. Probably probably I would have advised from my side in this situation get present. And then, yes, obviously, COP is what being done. Sequel is what.
Fever with rash, I think we have mentioned rash also. So rash should be because drugs only that patient has had some drugs.
So we were suspecting the rash to be drug associated,
Drug associated.
and the rash gradually improved and subsided after 4 or 5 days. So we did.
Actually, we got very perplexed and puzzled because the patient was asking every day. Fever is still there, my counts are rising, and this was the diagnostic dilemma. And then I think after this discussion, Dr. Vibu was involved day 2 or day 3. This patient,
Once he started worsening again.
yeah,
Teacher could.
yeah, he improved the patient. So, yeah, so what I think, everything.
So there's the issue of whether because patient when he is already taken the course of antibiotics.
Already antibiotic.
So we couldn't get that much of purchase.
No, this patient came very early to us,
Yeah.
4 or 5 days this week.
Generally, and but yes, generally they should come to some Rashika center. They already received some antibiotic or maybe some hospitals admission for instance and they for the patient. So I think the culture would actually make some sense. Suppose comes out with positive high counts and this.
Finally, we thought we have to explore in this time maybe some malignancy is there because of fever is there, high counts, or maybe inflammation is there. So and then
So I think poultry versus this foreign I think is a better option. Yeah, for
can protect plus also right. Fecal trends.
calprotectin is high in non-certification also. It doesn't say it's a special arthritis, but calprotectin can be high any API.
So, as we all discussed, given the ileocecal thickening on the imaging, a state of persistent inflammation and a non-contributory cultures and other blood investigation, and no response to broad spectrum antibiotics, a gastroenterology consult was taken and a colonoscopy with biopsy was done. So, this is the report of colonoscopy, video colonoscopy. So the rectum shows erythema and multiple linear ulcers. Biopsies were taken, and ileocecal junction valve show large ulcer. So a consideration of IBD and an infective etiology was made. So the biopsy report came, and it shows the ileal ulcer were just moderate active ileitis and with no crypt architectural distortion and negative for granuloma, protozoa, or dysplasia or malignancy. But the rectal ulcer shows moderate active inflammation with few superficial crypts showing crypt distortion, which could be which raises the possibility of inflammatory bowel disease. So a diagnosis of inflammatory bowel disease, query ulcerative colitis, was considered, and the patient was started on mesalamine and glucocorticoids according to the body weight. So we observed an excellent treatment response. The TLC and platelets started to fall. CRP got better. There was a resolution of neutrophilia, and symptomatic improvement was also present. The patient was discharged in stable condition on tablet mesalamine 1.2 grams and glucocorticoids according to the body weight. So now the steroids are being tapered off and the patient is planned for a repeat colonoscopy. So this case represent IBD presenting as pyrexia of unknown origin based on the case presentation.
I think this kind of IBD can present you. This is the cause of why because not just present technically.
This case was little, different because the history was very short, and we were not suspecting there was no history of suggesting of inflammatory bowel disease or family history of inflammatory bowel disease. So we were not suspecting it. But as the investigations unfolded and as the TLC and inflammatory markers were persistently high and the colonoscopy showed this, so we thought that this might be the first presentation of this disease in this patient, and rash also can be there inflammatory bowel disease. So this was little different in this patient. Dr. Vibu?
So patient responded to steroids.
Yes.
The diagnosis, at least on the second one, was inflammatory. There is a possibility that the patient had an infection to start with the first 6 days, and then something secondarily started an inflammatory response, initiating all this. If you would ask me, sir, a patient has come, you sent the patient for a follow-up to me. Patient is off steroid for 20 days.
Yes.
He's symptomatically fine, but his counts and platelets have again started rising. I posted this him for an endoscopy, colonoscopy, around 1 month from last steroid. So it will be undergoing colonoscopy next week. His calprotectin presently is normal. I'm still not linking him confirmed IBD. If at all IBD, he'll be Crohn's disease. I have my reservations. He may just not be IBD. But yes, a first presentation of IBD may present with fever, but still cannot explain high count. He's still having high count.
This patient came in follow and he was on steroid and we tapered off the steroids. And after, stopping the steroids for, as Dr. Bubu said, after 2 weeks, again his TLC started rising and platelets started rising.
No symptoms.
No symptoms. So, symptoms are pain. Yes, he's complaining of pain. Again, non-specific pain. Abdomen.
Was patient marijuana also?
Yes, initiation phase is hospitalized when he was hospitalized. Okay.
6 to 7 days we have.
Patient stayed for 15 days with us. Out of that, 5, 6 days or 1 week.
IBD with high counts is usually seen with infections slash fistula or perineal हो गया या फिर intra-abdominal sepsis. Otherwise, counts of 20,000 are usually not seen in IBD. Platelets can happen. Sir. Platelets can happen.
That is
Platelets
why
can happen with bad.
we were because patient was already every time asking. And on the top of that, patient's son, he's a surgeon. He is going to become more VIP patient. So because starting with steroid, diagnosis not being confirmed with high count. So the testing has been PSO protocol plus and patient having symptoms, persistent symptoms. And still we are starting steroids. Profile was normal. Yeah. So steroids, there's nothing in it. Steroids.
With this kind of presentation, acute infections seem unlikely. One differential tuberculosis in India or fungal infection. Biopsies did not feel anything. TLC was very high, which again does not suggest that tuberculosis as diagnosis. So yes, these two things were there, which were not, and for fungal infections, Polonic picture was not very suggestive of fungal infection. So by exclusion with him on being good antibiotics for 10 days plus call for steroids was due. Whether it was a underlying IBD and he would require all these medications for coming live throughout, for that I would need further evaluation. After stopping steroids, are his lesions coming back? People calculated repeated has been normal for now as well. But yes, it's not to get into for first episode, we need to start sometimes, right? It's always a
So I think it is the question of infection versus infection. So sometimes infection response. TLC, it goes high in response without patient showing symptoms, right? And I think steroids may be a double-edged sword at times, but if the patient counts high, patient running fever, so sometimes we don't have
both the things. IBD with secondary
we don't
infection.
say maybe the IBD underlying IBD, infection, it might fail, but it is very unlikely. The cell is still very short. Very short. Yeah. 6-7 days history as a
IBD में जरूरी नहीं कोई chronic history हो infection की वजह से भी IBD precipitate हो जाती है.
Sir, that first episode of it.
secondary infection का evidence नहीं मिला.
Sir, hemoglobin S.
Sir इनके सारे counts high हैं.
Now inflammation था.
ये तो inflammation. ये तो steroid से deal हुआ.
Counts के साथ so that is infection versus infection this is normal program. ठीक है, high count and then to be reduce the steroids. So it means totally normal. So it means there is some infection is going on. It's called high platelets and high count. We were scared of starting steroids, but then we decided that we have double-edged sword. Yeah, we were scared. Steroid, I think it's a double-edged sword. Sometimes people would ask you why you are steroids. Dr. Bibu also said you please start with steroid and
After biopsy, so I was scared till biopsy was there. मैंने biopsy से एक आध दिन पहले शुरू हुआ था. मैं यहाँ से biopsy की wait कर रही. उसमें कुछ.
So patient fever for 3 weeks.
No, sir, 5 to 6 days.
Unnormal. That's why you
Okay.
3 weeks.
Technically it's not.
So criteria wise 3 weeks. And or 1 week of intensive
So IBD presented with fever. I think IBD can start with fever, but IBD presented with high count and high platelets, I think would be a better. Yeah.
In the absence of identifiable dominant sepsis.
Okay. So, so based on the case presentation,
Then we
all were negative. So key features supporting IBD as the as the etiology of this case. First, the temporal evolution pattern. So initial presentation was isolated fever and systemic symptoms, absence of any localizing sign on initial evaluation, and subsequent development of GI symptoms after several days. Then progressive elevation of inflammatory markers despite negative cultures. So second, laboratory profile consistent with IBD. Markedly elevated CRP indicating significant systemic inflammation, elevated fecal calprotectin, specific marker for intestinal inflammation, and leukocytosis with neutrophilia, consistent with active inflammatory process. Third is the imaging and endoscopic correlation that the ileocecal thickening on CECT, colonoscopic findings with ulcerative lesions, and histopathological confirmation with IBD-like features with no granulomas. So the pathophysiological mechanisms, the presentation of IBD can be explained through several mechanisms. First is the systemic inflammatory response. So IBD involves chronic immune activation with elevated pro-inflammatory cytokines such as TNF-alpha, IL-6, and IL-1 beta. These cytokines act on hypothalamic thermoregulatory centers, which could cause fever. And systemic inflammation precedes localized GI symptom in some patients. And second could be post-infectious trigger, like in this case. This case represents post-infectious IBD, where an initial infection insult triggers chronic inflammatory bowel disease. The temporal relationship between pre-assumed enteric fever and subsequent IBD development supports this mechanism. Molecular mimicry and immune dysregulation function following infection leads to a persistent inflammation. So conclusion. This case exemplifies the diagnostic complexity of IBD, presenting as fever with leukocytosis, and underscores the importance of maintaining broad differential diagnosis in fever evaluation. Recognizing post-infectious IBD as a distinct clinical entity, understanding the inflammatory bowel disease can present with systemic symptoms before localized GI manifestations. Utilizing advanced imaging and inflammatory markers to guide the diagnosis, and considering the therapeutic trial in carefully selected cases. So the excellent response to IBD-specific therapy confirms the diagnosis and demonstrates the early recognition and appropriate treatment of IBD-associated fever leads to the outcome, emphasizing the clinical importance of this uncommon but treatable cause of fever of unknown.
Yeah. And it's a wonderful case, and sometimes we are stuck up like what to do, right? Because starting steroids, starting not to steroid, and waiting for antibiotics to respond. But if you are given antibiotics for a sustainable period of time, then definitely think out of the box at times, and we should start treatment like this. And diagnosis still is not very yes, but the best thing that we can offer is only that. And I think the culture negative profile is normal and high count responding to right. I think the patient needs a close follow-up. This is most important, and maybe another set of cultures would be given after stopping antibiotics, so that we can at least find some source of infection somewhere, and taking the food and hygiene habits of the patient. That patient taking some food or some water infection one person, and the history of infection in the surroundings that patient having. Because then yes, sometimes the patient have some common infection at the source that patient is getting this recent care. I think it's a wonderful case, and I talked to Dr. Bansal, present case, Dr. Vikram, and very good. You have the first year, and you have done a very good job. Quite confident.
Thank you so much.
And I think best of luck in your future endeavors. Thank you very much. So before we go moment to Dr. Vibhu Vikram and Dr. Rajman, so we have the Lifetime Achievement Award before that, and we conclude this. So any guesses who will get the Lifetime Achievement Award? Champion Award. So that time you also. So ETV Campaign Award is monthly. So just recognize this fellow.
Ashok Sharma.
So he is an excellent musician, but extracurricular activities, I think a very long due Dr. Ashok sir for this award. And actually मिलता नहीं सर कहीं नहीं मतलब इनकी छोटी करते हैं
I was surprised to see him here. मैंने कहा आप यहाँ कैसे आपको तो मुंबई में रहते हो.
So I welcome Dr. Ashok Sharma to say few things about what actually so time model is very close to this and this is एक वीडियो दिखाना वीडियो भी हो गए ये अभी लखनऊ में शूट करके आए 3 दिन पहले लखनऊ शूट करके आए बनने वाली वीडियो वीडियो पे आया था देखिए इनको और एक वीडियो भी हो गया था ये नहीं है अभी मैं
वीडियो तो तुम्हारा ही है बाय डिफॉल्ट
ये मॉडल की है So, foundation of Ashok can just tell us few things about the ethical film.
Medical professionals are doctors, other all professions are very easy. Writing or speaking or preparing a paper, presenting a rare case will take 1 week. Or acting, it hardly takes 1 or 2 hours. Just you have to rehearsal it, you have to make your own script, and you have to work it on. It's easy than giving a guest lecture or treating patients. And, my entry in Bollywood is just accidental. I've written one book, The Last Ride, and it was published by Penguin. Still, it is having 55 5-star review on Amazon and Kindle. It was recommended by Penguin for Hollywood movie adaptation. And later on, I am a registered actor with Street Casting Agency, Hollywood, as a Southeast Asian actor. I'm registered as a Screenplay Writer Association, Mumbai. I'm registered producer at Film Western India Producer Association, Mumbai. And I'm registered actor IMDb grade at Prasar Bharati and also in Bollywood. So after the book, I have making 2-3 films which are related to our profession. First is on